I am going to talking about disorders of fluids and electrolytes, vasopressin antagonists. Definition: ample evidence is available to implicate vasopressin, a small polypeptide that is synthesized in the hypothalamus and secreted from the posterior pituitary in the pathogenesis of most hyponatremic disorders. As the most common electrolyte disorder, hyponatremia is consistently associated with increased mortality and morbidity.
Vasopressin, also known as antidiuretic hormone, is an important mediator of water retention by the kidneys. Vasopressin is synthesized in the hypothalamus and stored in the posterior pituitary, from which it is released in response to decreased plasma volume and increased serum osmolality. Inappropriate vasopressin release reduces excretion and increases resorption of water, which may disproportionately expand the plasma volume, resulting in dilutional hyponatremia. Samska is the first and only oral vasopressin V2 receptor antagonist for treatment of clinically significant hypervolemic and euvolemic hyponatremia.
First, the treatment of hyponatremia has been by abusivity of controlled studies and by a lack of reliable and safe approaches. Therefore, the regulatory approval of vasopressin antagonist represents a milestone in the field. Cons: vasopressin is contraindicated in people allergic to the hormone. The drug should not be used in patients with vascular disease, especially for coronary patients. Constrictor effect due to their small dose of vasopressin can cause angina pain, and higher doses can ride a heart attack. Vasopressin may produce weather intoxication manifested by drowsiness, apathy, and headaches, which can lead to convulsions and terminal coma.
Phosphorylation of the microtubular subunits results in aggregation to form aquaporins, which are then inserted into the luminal membrane. Water enters through the aquaporins on the luminal side of the renal tubule and exits passively on the basolateral side into the capillary space. The action of AVP at the V2 receptor helps maintain plasma osmolality in the normal range by increasing free water reabsorption. When plasma AVP is low or undetectable, the kidney excretes solute-free water. Fluid coming from the proximal diluting segment of the nephron passes through the distal segment and collecting tubules without significant modification. As a consequence, the urine is dilute or hypoosmolar to plasma, and its volume and flow rate is high. Aquaresis is the increased excretion of water by the kidney without an increase in sodium excretion. AVP receptor antagonists, such as Vaprosol, conivaptan hydrochloride injection, act primarily by V2 receptor antagonism of AVP in renal collecting ducts. The effect of blocking this receptor results in the electrolyte-sparing excretion of free water, or aquaresis. Disrupted AVP secretion frequently results in an imbalance of salt and body water. Increased AVP secretion leads to decreased free water excretion, resulting in water retention. When this causes an excess of body water relative to sodium content, the result is dilutional hyponatremia. In patients with euvolemic hyponatremia, the total body sodium is unchanged and total body water is increased. However, there are no clinical signs of edema. Syndrome of inappropriate secretion of ADH is the most common cause of euvolemic hyponatremia. SIADH is seen when plasma levels of AVP are elevated at times when physiologic AVP secretion would normally be suppressed. Causes of this syndrome include CNS disorders such as subarachnoid hemorrhage, meningitis, and head trauma. Other causes of SIADH include pulmonary disorders such as pneumonia or carcinomas. Total body sodium and total body water are increased in hypervolemic hyponatremia, with total body water exceeding total body sodium. Hypervolemic hyponatremia is detected by the presence of edema or ascites on physical exam. Hypervolemic hyponatremia is seen in patients with edema forming states such as congestive heart failure, liver failure, and nephrotic syndrome. Specifically, in the case of hypervolemic hyponatremia caused by heart failure, reduced cardiac output results in relative arterial underfilling and triggers the pituitary gland to release AVP. Arginine vasopressin plays a critical role in maintaining the balance between salt and water. Disruption of this balance may decrease serum sodium concentration. AVP receptor antagonists like Vaporsol, conivaptan hydrochloride injection, represent a unique modality for the treatment of delusional hyponatremia.
Uses applied in Ecuador. Vasopressin is used in conventional medicine for the prevention and treatment of post-operative abdominal distension, in diabetes insipidus, and in preventing the formation of soft shadows on abdominal radiography to keep the normal weather balance.
So where does ADH come from? Well, ADH is secreted by the posterior pituitary gland. However, ADH is actually produced by the hypothalamus in response to an increase in plasma osmolarity or a decrease in blood volume. An increase in plasma osmolarity basically means when you have high solute levels in the blood in respect to water. Sodium is a strong stimulant here. If sodium levels are high and if the blood volume is low, it will stimulate the hypothalamus to produce ADH, which will then travel to the posterior pituitary to be released into circulation. ADH is also known as arginine vasopressin. ADH travels to the nephron, to the distal convoluted tubes and the collecting duct, where it will stimulate the expression of aquaporin type 2 channels to reabsorb more water back into circulation. In summary, ADH targets the distal convoluted tubules and the collecting ducts of the nephron. It increases aquaporin type 2 channels, which increases water reabsorption and so increases fluid volume and also decreases plasma osmolarity. ADH also has an effect on peripheral resistance. There are ADH receptors on blood vessels. When ADH binds, it can cause vasoconstriction, which increases peripheral resistance, and so can increase blood pressure. However, ADH's role in vasoconstriction is mainly during a lot of blood loss. The next hormone which is important in maintaining blood volume, fluid homeostasis, is aldosterone, a mineral corticoid which is released by the adrenal cortex of the adrenal gland. How does aldosterone get released and what does it do? When you have low blood volume or low blood pressure, it will stimulate the renin-angiotensin-aldosterone system, or RAS for short. RAS stimulates essentially will lead to the stimulation of aldosterone from the adrenal cortex. Hyperkalemia, high potassium levels, and low serum sodium levels can also directly stimulate aldosterone release into circulation. Aldosterone is a mineralocorticoid and thus binds onto a transport protein in circulation, mainly albumin, but also transcortin, a protein also produced by the liver. Aldosterone travels to the distal convolute tubule of the nephron. Here it increases the expression of ENaC and sodium-potassium ATPase pumps. What this means is that aldosterone will essentially result in the reuptake of sodium from the nephron tubule into circulation. And as a general rule, water will follow sodium, and so you increase the reabsorption of water as well. So in summary, aldosterone targets distal convolute tubules, where it will increase ENaC channels and sodium-potassium ATPase, which will lead to sodium reabsorption and therefore water retention, which will increase fluid volume and also decrease serum potassium at the same time. The final hormone in maintaining blood volume and fluid homeostasis is the natriuretic peptides, which have the opposite effects of ADH and of aldosterone. The natriuretic peptides are released by the heart, specifically the atrium and the ventricle. Natriuretic peptides have opposite effects of ADH and aldosterone, and so the trigger of its release differs. High blood pressure and high blood volume will cause stretching of the heart wall, which will trigger the release of ANP and BNP. ANP and BNP are your natriuretic peptides, and they will inhibit the activity of aldosterone. And they will do this in a few ways. One, they will decrease sympathetic activity, which will inhibit essentially the release of renin, and so will inhibit the renin-angiotensin-aldosterone system altogether. Natriuretic peptides also cause afferent arterial vasodilation, which will increase glomerular filtration rate. When you increase the glomerular filtration rate, this will tell the juxtaglomerular cells at the head of the nephron to stop releasing renin, and so will it inhibit the renin-angiotensin-aldosterone system altogether as well. Finally, the natriuretic peptides also have a role in blood vessels. It has the opposite effect to the antidiuretic hormone. The natriuretic peptide binds onto natriuretic peptide receptors on vessels, causing vasodilation, which will lead to a reduction in peripheral resistance, which means it will also decrease blood pressure.
Conclusion: the advent of the use of vasopressin antagonists as progressive sessions with a new means of increasing the plasma sodium level in patients with hyponatremia. These agents appear to offer substantial advantage over previously available therapies that have been shown to have limited efficacy. An unacceptable side effect profile, or both, to ascertain whether such increases in the plasma sodium level have an effect on mortality and morbidity associated with hyponatremia is a challenge for the next decade.